ADHD certainly is very often underdiagnosed and misdiagnosed. I think that the problem with getting clearly the problem with clearly identifying a set of behaviors as ADHD versus other things is that one, we're talking about developing children, so 5-year-olds are somewhat hyper compared to 15-year-olds, right, or 25-year-olds. They're less attentive, and so some of these behavioral, some of these behaviors and the symptoms that are experienced are a part of a normal subset of development. The issue is their frequency, their intensity is much higher, and the impact is higher. And so we may misdiagnose someone with ADHD with a learning disorder. Oftentimes, the bigger problem, I believe, is that instead of being identified as ADHD, they're mislabeled as disruptive, misbehaving, kind of intentional, willful misbehavior. And why that is so important is because that then, one, labels that child as quote unquote bad, and additionally, it pulls that child out of the realm of taking a clinical approach to understanding what they need and then helping make accommodations and get interventions to help them. You know, a child that's bad is bad, that's the parent's fault, they need to figure that out. A child with ADHD that's disruptive because of those symptoms should receive support, care, and accommodation so that we can maximize their ability to learn and proceed in their normal developmental path. And so I think those are some of the most common diagnoses. Sometimes I'll see children that have ADHD that were diagnosed with an autism spectrum disorder as well. And I think that, again, part of that is getting to the looking at the behavior or the symptom, but tracking that back to the core, what the etiology, what the source of it is, which brings us a clearer understanding of why we're getting that behavior, and is more likely to get a accurate diagnosis. I think there are multiple factors as to why that happens. One is a lot of the times, you know, the area of the highest level of behavioral and emotional cognitive performance for kids' school, right? And so, not that the teachers don't have plenty on their plate, but there's a oftentimes ADHD isn't on the radar. Oftentimes, if we want to pull in talking about, you know, minority populations, there's a lot of inherent biases and interpretations at play, even in the most well-meaning individuals, that can lead us to see a behavior in a young Black child, a Latino child, and then because of those biases and those assumptions, we interpret that behavior as, you know, this is a child who's grown up in an impoverished area, and this is how a lot of those kids act, or you know, attributing the cause of the symptoms as behavioral, as opposed to a child who may have a condition that would be responsive to support and treatment. And so those are some of the larger factors that I think play into how we would see or understand these symptoms in a minority population differently. I'll add one other piece. You know, we can talk about the difficulties in access to care and the disparities around that. But even for those minority children who are able and fortunate enough to enter the healthcare arena, the implicit biases that we talk about, which don't really seem to have changed much even since the 1950s, they still exist in the providers as well. And so for a psychiatrist, a psychologist, a therapist to meet with a minority child and evaluate their experiences, we've seen that there's a tendency to diagnose more severe conditions. There's a tendency to attribute cause to simple poverty or parents' educational level, things like that. There are even studies that talk about just natural empathy, how much more difficult it can be, or the varying levels of empathy we show for someone who is within our culture as opposed to outside of our culture. And by empathy, I don't mean that we don't want help for them or that we don't care what happens. I'm talking about empathy in a way in which we can understand their experience from their perspective, which then gives meaning to the symptoms. And so, if you know, a more well-known example that's not inclusive of ADHD, but these things are connected because it's the same health system providing the care. It's the higher diagnosis of schizophrenia in African American males versus a mood disorder and folks who are non-minorities. And so part of that again is we have the behaviors, we have the symptoms, we have the life experience. Our lens that we understand that is affected by our own personal attitudes, experiences, and perceptions. And so no one is without bias, right? And then when we talk about racial or cultural bias, that tends to lead a provider to make clinical determinations and evaluations that would steer away from something like ADHD to something more like a bipolar or autism or other types of diagnoses.